So let's look at hormonal contraception, and I'm going to talk about the oral, and I've included the hormonal patch here, also something we don't have a lot in public sector because the side effects and the contraindications are all very, very similar. And I do think we sometimes don't talk enough about the combined oral contraceptive pill. It's a very good option. Although, you know, we say it's easier to have your injection every 3 months, actually women are very good at getting into a habit of taking their pill every single day. They have it next to their toothbrush if they're motivated not to fall pregnant. This is actually a great, also a great option for somebody, for example, who doesn't want to have the injections. We've got 2 pills available in the public sector. So the one is the monophasic one. That's the classic one with 21 tablets of your ethinyl estradiol and your levonorgestrel, and then the 7 placebos. We do have triphasal. I was trying to figure out why we use triphasal. And the idea initially when it came out was this idea that it follows the natural cycle and therefore is slightly better tolerated. But actually the evidence around triphasal as a much better method than the monophasic is not great. I know, and this is 20, 30 years ago when we used quite a lot of triphasal, it was very cheap. So I don't know if that's another reason why it's been popular within our settings, but usually most oftenly because it's quite simple to explain to the patient. They've got their 21 tablets, that the active tablets that they take, they've got the 7 placebo tablets that they take, and it's a little bit more easier to use. So what's great with it, as I've mentioned, is if somebody's already got PMS or dysmenorrhea or problems with their menses, the oral contraceptive pill can control it. And do remember it for our patients with acne, especially in the public sector where we don't have a lot of options for acne treatment for example, for a teenager. So if she's got acne and she needs contraception, then maybe the oral contraceptive pill is quite a nice option. This is the one where the problem with it is, and we'll go through all the contraindications in a moment, but particularly you can't use it in deep vein thrombosis. So estrogen does increase your thrombotic risk, not a lot, but we've got a lot of people on contraception, so it is significant in our population. And as I've mentioned, we don't want to use it too quickly postpartum. Then we've got our progesterone tablets. This is our so-called mini pill. In the public sector, we've got levonorgestrel, 30 milligrams daily. So you just take them every single day. And the big advantage of your POPs is that it actually also wipes out your menses. So some patients don't want to have a period. And then the POP is is a very nice option. But also because it doesn't have the estrogen, it is much safer in that over 35-year-olds that are smoking or obese or have other cardiovascular risk factors. So if they want to have a tablet, but they've got other risk factors, then your mini pill is a better option. It's supposed to have a lower contraceptive effect. Oh, I realized I haven't put the percentage in here, but it's still very good. It's still under 1%. So it's not quite as good as the oral contraceptive pill, but it's actually still got an excellent efficacy rate. But as the problem with all of our oral things, obviously, is there's no STI cover. This is just about the patch. I thought it'd be interesting to know that there is this patch available. So these are people who don't want to take a daily tablet, but wants to be on and it works exactly like the pill. But it's a patch you put on every single week, and then you have a week-free patch. And so at Discam and Clicks, it costs between 240 and 280 Rand a month. So it's obviously also for a very particular population. The side effects and things are very similar, except you also obviously have the problem with the rash where it actually gets put on. And it's called EVA in South Africa. And then there's particular rules on what you do when the patches comes off, but you don't have to worry about that. You're not going to be prescribing that anytime soon. So in terms of side effects, so there are particular side effects that's very specific to the progesterone-only pill, and there's obviously things that overlap, but the progesterone-only pill, obviously the periods stop, which is great, but it also means that you can have more spotting and more in-between breakthrough bleeding, and so that can be a bit of a pain for some. A little bit more acne with a progesterone-only pill, where your oral contraceptive pill actually helps for the acne. And then very important with the oral contraceptive pill is the weight fluctuation. So some people finding actually that their weight fluctuates through the month, but some people also find that they gain weight on it, which not for everybody, but that might not be a side effect that's very well tolerated. Some people can have things like breast tenderness. They can have headaches during the active pill. And some people actually, again, get like a sort of a PMS even on the oral contraceptive pill. So because it's hormones, there are very specific contraindications, important for both the POPs and the COCs if they've got a bleeding of unknown origin. So you don't just want if somebody has periods all over the place and you don't know what's causing it, you don't want to put them on hormones until you've figured it out. And with both of them, liver disease are potentially a problem. But important with our oral contraceptive pill is that there's over 35 years that I've mentioned. So we need to think a little bit carefully if they're smoking or they've got cardiovascular risk disease. In this particular guideline, this is in the EML, severe or uncontrolled hypertension is seen as a contraindication. And very important, if they've got a history of DVT at any age, you can't use the oral contraceptive pill. So what do you tell your patient? You want to take them the same time every day without interruption. Sometimes people get a little bit nauseous, so you can give them some metoclopramide, and it's usually just in the first month. And you want to tell them that if within 2 hours of taking the tablet, and this might not even be related to the tablet, they might have had gastro, and they vomit or they've got severe diarrhea, they must just repeat the dose. A dual method of condoms is obviously always advised, and one needs to be a little bit aware that it can interfere with some other medications, or medications can interfere with that. So again, that's our failure rate, and you can see an excellent, if we take it well, 0.3% failure rate. But the big challenge is this being able to take the tablets daily. So, but you can see, even with people who are skipping quite a lot, we still have an under 10% failure rate on the pill. So what you're going to do is you're going to make sure, obviously, that they're not pregnant. You can start the pill any day in the cycle. It doesn't matter. The reason why we often start on the first day of the period is because then you can be very sure that they are covered in terms of prevention against pregnancy. But if you give it at any other time, you're going to tell them, give it at least 7 days before you're covered. You need to use condom for 7 days or abstinence for 7 days before you can be sure that it's protecting you. And with breastfeeding, we will. It's actually, the guideline says to prescribe at the cessation of breastfeeding or 6 months postpartum, whichever comes earliest. So it does mean you can actually give the COC after the 6 months. And they can actually therefore breastfeed with the COC, but only after the 6 months. So there's nice little bits of advice on what to do with mist-only pills. For me, with patients, sitting them and explaining to them what to do with missed pills is a bit of a waste of time, because they're going to miss a pill 2-3 months down the line and they're going to panic. So they need to have a nice clear leaflet or something written down about what to do when they miss a pill. And the general rule is, if you do miss a pill on the day, obviously take it as soon as you remember, but you want to be able to make sure that you cover with condoms, for example. And if you have one pill forgotten or taken 3 hours late, this is for progesterone only pill, and you've had unprotected sexual intercourse, you can even consider emergency contraception, but it's quite dramatic. The COCs is a little bit easier when you miss pills. And it also depends when in that, because remember, you've got your 7 days placebo days. So if you miss closer to the 7 days, then also emergency contraception might be needed. If you miss it later in the cycle, then it's then you can actually just relax and continue through the placebo stage. So if you think about it, once you've taken 21 tablets, you are skipping 7 tablets quite safely. So it's actually skipping tablets during your COCs is not quite such a train smash as long as one follows the rules. So again, just make sure you give them written instructions on what to do, because it gets a little bit fiddly. This is the medicine interaction table from the EML. And rifampicin as well as rifabutin, they both interact with oral contraceptives, and they're enzyme-inducing medicines, which means they reduce the effectiveness of your contraceptives. So the challenge is one of these tablets is going to cause the possibility that you might fall pregnant, okay? So you are preferably going to look at a different method completely, but your particular epileptics that's a problem is your phenytoin, your carbamazepine. Luckily, we are not actually using any of these antiretrovirals routinely any moment, but it might be important in our third-line patients who are on ritonavir. So those who are on atazanavir, ritonavir, or darunavir, ritonavir, we do want to avoid the estrogen-based contraceptives. Lamotrigine is interesting. So lamotrigine does not get affected by the oral contraception, no, the lamotrigine doesn't affect the oral contraception, but the oral contraception might affect the lamotrigine dose. So there is a potential increased risk of seizures. So again, in this scenario, you might decide to rather explore other options. But if somebody's already on lamotrigine and there's no other options, you're just going to have to be watching them closely. But the chances are it's going to be easier to look at another method. So even lamotrigine is not a good option with hormonal contraception. So breakthrough bleeds on contraception is sometimes a problem and sometimes an issue. For our Provera, our progesterone-only injectables, you can use something like your COC that's got some, so just a classic oral contraceptive pill just for 14 days usually sorts it out. If you, similarly for our progesterone subdermal implants, similarly just the oral contraceptive pill that we have, and you'd use that for 20 days and that usually sorts it out. And then we'll talk about the Mirena in a minute. And then for the oral contraceptive pill, they basically say change it. So and we don't actually have a lot of options available within the setting. So you might have to just look in terms of potentially alternative options. Great. Just to warn you, we are going to go over time. It's Friday, but I thought let's rather do this properly and make